There we go. Okay, you guys see my screen?
Yes, indeed.
Awesome. Okay, so I am Nadia Merchant. I am a pediatric endocrinologist and geneticist. It's my honor to come and speak to you guys. I feel free to, I guess, if you want any ask any questions, I will try to keep track of the chat box also. But I'm going to give you a little bit about what do we do from a clinical diagnosis to gene discovery and emerging treatments. And I think this is a really exciting time to be thinking about a lot of this at this time. I'm going to take it from from mostly one diagnosis perspective, is because obviously I can't cover everything in genetics. Just my disclosures. So the objectives is to how do we approach growth, the classifications of growth, and then the evolution and future of growth plate therapeutics. So I myself am 3 feet 6 inches. I have a skeletal dysplasia myself. And I'm going to kind of go through a little bit of my journey because what led me to why I'm interested. I was born and grew up in Houston. And then I was diagnosed with severe skeletal dysplasia when I was a child. And we moved to Saudi Arabia. So from Houston, we moved to Saudi. And I guess that would classify me as a third culture kid because we were coming back and forth. And I really got to see and interact with all types of people from all over the world by doing that. And since we were living in Saudi, I decided to go to Cornell in Qatar. I was planning going to college in Texas, so that would be where I would have gone probably. But there was this new med school that opened up that had a 6-year program. And so I decided to go there, which was really a great experience and really opened the world in different ways for me. I did my residency at Dane Children's, which is is the only pediatric military civilian combined residency program. So half of my class was active duty, which was really a great learning experience from that standpoint. And I really enjoyed my residency there. And then I went off and did genetics initially, and I really enjoyed my time, but I really felt like I wanted to follow kids more closely and instead of just doing mostly diagnostic. It, so I decided to do another 3 years of training. Some people would think I'm crazy to do that. And then I joined faculty at Children's National in Washington, D.C. And this is kind of where I've been. And I think it's always interesting to know like what people's career paths are in whatever they do. But especially in medicine, I think we all have some unique paths that we come through. So one of the things I do see is a lot of children coming in for evaluation of growth because we see kids with puberty, hormone related, and just parents' expectations and child's. So what are some of the common things that people have said to me, or at least some quotes I'm going to say? So someone told me, if my child is not 6 foot tall, he cannot be a CEO. My child did not make the varsity basketball team since he is 1 inch shorter than the teammates and 30 pounds less. And knows football. My son was the shortest at his birthday party. Let me show you a picture. My 8-year-old daughter is taller than my 10-year-old son, which is very difficult for him when people assume my daughter is older. My child is shortest in the class, 10th percentile on the growth chart. She gets picked on all the time. So these are some of the questions that come up, and this is just a normal growth. I'm going to kind of go in a little bit more into genetics, but I think just knowing that kind of what society we live in and what things that come up and people will say and why they may come to endocrine. So first off, I say, what can I not do? I need to drive a car with extensions. Most Disney rides, a lot of them I can't go on. And so, but I use a step stool. Sometimes I agree, I'm too short for the door to detect me at the DC airport, but rarely happens. But let's kind of talk about really factors that impact growth. So if I have a child coming in for growth evaluation, they could have an underlying skeletal dysplasia as such. But I want to know, is there something else going on? So when we think about endocrinopathies, we think about, is there a growth hormone issue? Thyroid issue? Have they been losing weight or gaining weight based on high or low thyroid? Is there like puberty? Are they like going through puberty in normal age, or is it delayed? Those are things that generally we think of the classical endocrinologist is going to treat for or follow or reassure parents that everything is going well. Then we have like the category environmental influences. So a child's like whether there is food insecurity, child's not been eating enough nutrients, that can affect the height a little bit too. And then we have the biological influences, like did somebody get diagnosed with celiac disease? Or were they put on steroids because they were diagnosed with cancer of some sort. And then, or they have like impaired motor skills. So like they have contractures. And so you really can't get accurate measurement. These are all things that in some ways, you have to treat the underlying condition, because if you are on a certain medication like steroids, I can do anything and everything to help, but probably unless you come off the steroids, it's not going to help as much. Or we sometimes diagnose kids with celiac, gluten allergy, but because they are not growing as well, and that's the only sign, they may not even have abdominal pain. Then there's the whole category of genetic disorders, which could be skeletal dysplasias and Turner syndrome, where you only have one X chromosome that may be slightly shorter on the growth chart. And there are all these other category of genetic conditions. And I'll talk to you about, there is a huge group of different conditions in that category. So how do, like initially when somebody walks into the clinic, how do we approach growth? First off, saying, where are they on the growth chart? Where are mom and dad on the growth chart? So how far are they away from the parents' heights? Their growth velocity. So how much have they been growing between 2 visits or between the last year? So knowing whether or not the child has not started puberty or has started puberty makes a difference, because a prepubertal growth rate is about 4 to 6 centimeters a year, where a pubertal growth rate is 8 to 15 centimeters a year. So if a child's in puberty and they're only growing like 4 or 5 centimeters a year, I'm a little bit more worried about something going on. And so that's really important. And we sometimes will follow these kids over time to kind of make sure they're growing at an appropriate growth rate. And then there's the medical history. Do they have inflammatory bowel disease or any other conditions? And whether they're proportionate or disproportionate in body habitus. So their trunk to their upper and lower extremities. And then we'll do further testing to figure out if there's anything else we're going on based on that. But that's kind of just the initial approach we take for a short stature evaluation. So what's a midparental height? This is a great happy hour conversation, or something that you may bring up with somebody like, oh, do you know that your height's kind of is related to your parents' heights? So there is this midparental height calculator you can find. If you really literally Google midparental height calculator, this EBM calculator pops up, and you put in the mom and dad's height, and you put in whether the child is male or female. So if the mom is 4'11" and the dad is 5'7", then the son would be predicted to be around 5'5.6", plus or minus 4 inches is, I say, roughly 2 standard deviations. And so that means that the boy could theoretically be anywhere from 5'1.6" to right around 11.6. 9, sorry, 5'9". Then there is the, like, what if and then you have the same thing in a female, and you get that there would be 5'0.4 inches. But what if the child's parents are taller? That makes a big difference, right? If you have a 5'8" mom and a 6'2" dad, then they're going to be around 6'1.6" for a boy, and for a girl, 5'8". Now, that's really interesting, because you have to know what the parents' heights are relatively to know where they're going to be. You can't have a 4'11" mom and a 5'5" dad and expect the kid to be 6 foot tall. And if the kid is, then I may be questioning, is there something going on that's genetic and that doesn't make any sense? There are other factors that may be in the parents' medical history, that maybe they were one of the shorter siblings compared to the rest of their siblings. And so I think that the midparental height is really important. It is a big range. We say plus or minus 4 inches, but even when you look at growth charts, it makes sense. It's still, yes, it's a big range, but there's a big difference between the 75th percentile and the 3rd percentile. So when we talk about growth, there's the environmental and the biological influences. I'm not really going to go into that much, but there are factors. You always want to make sure that you know what meds there are. You want to make sure they're healthy and they've been gaining weight appropriately. But ADHD meds. So ADHD, there is a question whether or not ADHD meds can affect growth a little bit. And a lot of it has to do with how the children eat. Like, do they really eat a good breakfast before their meals, before they take their meds? Because it does suppress their appetite, what type of food, how many years they've been taking it for. And so this always comes up. And sometimes I think that some of the kids wind up maybe 1 to 3 inches shorter based on if they've been on ADHD meds or not. But really, we got to counsel these kids. and families and make sure that the kids are eating appropriate big meals before breakfast and maybe a late dinner once the meds wear off. So now let's look at the growth plate. So I'm all about genetics. And so I think that it's important that this is more of a hormone. Let's go to like, what are the different factors at the growth plate? And can we understand what treatments may be helpful? So there are on the side, you see, there's a lot of different. So there's growth hormone is a positive effect on growth. There is the estrogen is a positive effect, but estrogen also closes, it calcifies. So it closes the growth plate eventually. So it makes you stop growing. And that's why once you go through puberty, you eventually stop growing. So all of these, I'm not expecting you to memorize this or know this in really big detail, but it just gives you an idea. There's so many factors that play into our growth. Steroids. Now, steroids are given very commonly for all sorts of reasons. It's like one of the meds that they love to throw on for if you have any inflammatory condition or you have asthma exacerbation. And I think that we underestimate how the effective steroids can be on kids. One, it's not great for the bones, but also it does affect growth. So for Duchenne muscular dystrophy, if a child who is diagnosed and is slowly not as ambulatory or being able to walk as much anymore, they'll put them on high dose steroids. And suddenly you have a kid who was growing really well, got started on steroids, and then they slowly stopped growing. And that is because the puberty is suppressed by the steroids, but also they're not growing as much. So you want to know whether or not they've been on steroids, and then you can treat accordingly. So now comes the big question of growth hormone. People love to come into my clinic and say, I want growth hormone. I want my child to be taller. Or the child has heard that one of his friends was on growth hormone because to make him taller. So when did growth hormone come around? So the first growth hormone treatment really didn't come into the market and approved and been readily used until 1985. So I always tell the parents that I'm like, growth hormone's only been around since the 1980s. Maybe you were on it, but people not much older than that, which means that we don't know what the long-term effect is in the 70s and 80s age group. It is considered as so far a pretty safe drug, but we have to, depending on what your underlying condition is, if you have growth hormone deficiency or not, you need different doses. So if somebody's growing normally, you'd have to give a really high dose of growth hormone to help them grow an extra inch or two. And it's a daily injection for like 5 years. Big question is that even worth it? And it costs like 20 grand a year. But that's a whole different story. But growth hormone has only really been approved and been used readily since the 1980s, late 1980s, really. And then now they're like trying to work on some long-acting growth hormone, which is like weekly. They've had that come on and off in the market, but we really haven't had one. Now we're hoping this one that we have now is going to be more useful. So the FDA over time has approved a lot of different growth hormone indications for growth hormone. So you have like pure growth hormone deficiency where your body's not producing growth hormone. And that's when it initially came out for, because those children would sometimes have low blood sugars because they don't produce enough growth hormone. Then came along other conditions like chronic renal insufficiency because of the chronic kidney disease. They are not growing as much, so that helps them grow. And then there's genetic conditions like Turner syndrome, which growth hormone has been helpful for. Prader-Willi syndrome, they started them at a young age because it may suppress some of their appetite from being over, and it helps them overall. And then came idiopathic short stature, and this is the category I was referring to earlier. Was like, why are they relatively short? Can it help them grow? And it has been approved in certain criteria for that. And as you can see, we just think, oh, it can help everybody. There's a little bit more to the story, but there's a lot of different reasons growth hormone can be used. And it's the only form we have is an injection. It's like an insulin injection. It's not like there's no pill form of it in any way. So how do you evaluate for growth hormone? So now this is a typical kid. It's like the parents might say, everyone I know is on growth hormone. Am I missing out on something? It's a little embarrassing. For a guy, it says something about masculinity, protect short-term and long-term, not aesthetic. That's why I'm giving it. I always like to give some parents references of like, there's this coming up short podcast that's kind of interesting to listen to. And then there's weighing the use of growth hormones for children. There's both sides of the thing, but I think we live in a society, I think that's really social media dependent, being like, we expect people to look a certain way, be a certain way. And I think that instead, I often want to counsel these kids like, be confident who you are, and your height isn't your success. Because I wonder psychosocially sometimes if by putting a kid on growth hormone and they really don't need it, whether or not it affects them negatively or positively, and even how they perceive people, right? If something they see, if they were on growth hormone because they were short, then are they going to think differently about somebody else who isn't as tall? Now, there's also this phenomenon, what we call constitutional growth delay, where you're growing on the same curve and then you kind of get behind based on your age. And then eventually you catch up because you had delayed puberty. And for that, is because you just were a late bloomer. And then eventually you'll be growing first year of college, where most boys are done growing by the first year of college. And then let's go into the skeletal disorder. So that's what we talked about, general growth evaluations. Now there are obviously skeletal dysplasias, which really, everybody, you can see them and you're like, something looks different. And when we started with skeletal dysplasias, there were very few, and most of them were clinically diagnosed. Now we have 437 genes in the most recent nosology that came out in 2019 because of the advancement in genetic testing. And there's and majority of the conditions have a gene, 92% have a gene that's been identified for them. So they can be categorized by genes, phenotype features, and affected bone segment. So initially we'd say clinical diagnosis based on the clinical features, the bone segment affected. And now we can say, well, this is the genetic diagnosis, and there are multiple genes maybe causing a similar clinical diagnosis. I hope I'm not going over your head as I'm talking about all of this very genetics can be a little bit complex, but try to make it easier. So there are three big categories of skeletal disorders. Dysplasia is something that happens over time, and it's specifically at the growth plate mostly, where the condition are at the bones level, where it's there is chondrodysplasia, which is the typical like skeletal dysplasia, and then osteodysplasia, where you have like abnormal like OI, where osteogenesis imperfecta, where you have the abnormal bone formation and you're at risk for fractures. This is something that evolves over time, versus dysostosis is like something that you're born with and it stays the same. So cleft lip palate, you're born with it, you don't develop any other issues, that is what you have. So that is something that's more, it happens in the as a fetus, and then it doesn't change. Where dysplasias evolve as a condition, and oftentimes sometimes you won't even know somebody has a dysplasia until they're born and then start growing, and then they're not growing as well. Then there's this whole element of metabolic conditions that is due to like the metabolism of how the bones work. And so, or like the lysosomal storage diseases, where you have like abnormal breakage or like increase in certain types of lysosomal breakdown, and that increases and causes certain features. So these are the three main categories of skeletal disorders. But when we think of little people, or we say most people think of like skeletal dysplasias. A skeletal survey is really the most helpful thing. And even to this day, even with advancement in genetic testing, we'll often get a skeletal survey to see what is affected, because then you have more of a specific diagnosis. And the hand x-ray is something really we use a lot in pediatric endocrine, because we can figure out whether the kid's chronological current age is consistent with their bone age. If they're delayed, then you know that could mean that they're a late bloomer. But in general, we look at the hands but also all the other x-rays. Then we do proportion. So as you can see, you have a larger head compared to your initially when you're born. And then over time, your upper to lower segment becomes about 1-to-1. And that's why it's really helpful. So you can do normal physical measurements and figure out whether or not, based on the age of the child, whether that is normal or not. So as you can see, your body proportion segments change as you get older. There are some ethnic differences in upper to lower segments also that we could take into account. And then when you're talking about skeletal dysplasia, you're trying to break them down. You're like, okay, do they have shorter limbs and the trunk is normal, like you see in achondroplasia, which is the most common skeletal dysplasia, or is their trunk more affected, or are they proportionate in every way, but they just are slightly smaller? And that's like a growth hormone deficiency would cause that, where if you have abnormal proportions, then you're thinking more of a skeletal dysplasia. So when we're looking at x-rays, we want to know what is affected, where on the growth plate. Is the vertebrae affected? Because that gives you lots of hints to what the clinical diagnosis would be. And so we look at, for example, if you have the skull is affected in achondroplasia, in cleidocranial dysplasia, your clavicle is absent. And that is something that's what you look for. If you're having other like the spine is severely affected in a lot of the lysosomal storage diseases. So those are different hints. And then when you're looking at the appendicular skeleton, is it the upper or the lower? So rhizomelia, which is more closer to the trunk, versus meso, which is like the close further out, and then acro is like when the hand is affected. So those are all different hints of what kind of skeletal dysplasia someone may have. And then the histology of the growth plate, really. So when you do see what's affected at the growth plate, you could also see, is it where in the growth plate? Is it closer to the core or is it closer to the peripheral bone? And that can give you an idea of what the diagnosis is. That's how we used to be able to diagnose skeletal dysplasias. And then now we can do further gene testing. I hope you're not getting bored. But this is a lot of different genes. And what I really want to explain is that other than skeletal dysplasias, which obviously is one gene having a significant effect, we do know that somewhat the variation between siblings occurs because there's like the 1% effect of lots of different genes into height. So did you get the taller genes or the shorter genes from your parents, which each may contribute to 1% of your height? And that's also maybe what leads to some of the variation in siblings. As you can see, there's so many different genes that we all inherit that all affect height in different ways. So now let's go in the genes at the growth plate. There is the extracellular matrix. There is the hormone kind of like regulation that happens here, and then at the growth plate. And then there is like other intracellular processes, and different of all of these if there's a mutation in any specific one of these, it can lead to different conditions. So the most common I'm going to talk about is FGFR3 because that leads to achondroplasia, and that's majority of people. They'll be like, I know that's skeletal dysplasia. I've seen them around. And that is a transmembrane receptor in the fibroblast growth signaling pathway. Now, we most commonly think of in that condition is achondroplasia, but depending on what the gene mutation is or variant, it can cause lots of different conditions, and the severity varies. Now, achondroplasia, there's only one hotspot, meaning there's only one place where the gene mutation occurs and it causes achondroplasia. Versus there are lots of different gene changes that occur in different conditions, and that in the same gene, but it's all about the mutation and where it occurs and how it affects the gene and its function. So achondroplasia is autosomal dominant. About 80% of cases arise de novo, which means that achondroplasia, 80% of the children born are born to average height parents. So 80%, so majority of children who have achondroplasia, it's a de novo, meaning that there is no family history of it. It is autosomal dominant, so they only need one mutation. So really when the embryo was being created, the mutation occurred, and that's how it happened. So majority of the cases are with average height parents, and it is the most common disproportionate stature where they have rhizomelia, so they have shortening of the of their extremities, and this especially the one that's more proximal near your butt trunk. And then you have a disproportion on your head. They can have some spinal, like kind of, it makes it like a rounded spine. And then they have the trident hand is something. So it's like, there's even an emoji for it on your phone, on your iPhone you can find, which really comes from Star Trek. But that's the way their hands are, interestingly. So then we're going to go into the FGF-CMP pathway. So this is where FGFR3 is affected. Now, if you look, there's so many genes that are affected and that are affected in this. And by now, us understanding all these different genes, the question is there any kind of treatment, or can we do something to decrease the complications? Because now we know where the pathway is. And now you've not only identified the diagnosis, but now you know, okay, this is the gene. What can we do to help affect the condition itself? And that's really what led to us understanding more about what happens if other gene mutations occur. So NPR2 is on the other side, but both the pathways kind of converge together. And that is a gene that encodes for the receptor. If you have If you're a carrier, meaning you have only one mutation, then you're slightly shorter the general population. And sometimes with NPR2, people are diagnosed with idiopathic short stature, meaning like short stature from unknown reason. But then when you do gene sequencing, or if they have a child that's affected with two mutations, then they're like, oh, that was the cause. If you have NPR mutation that causes the other extreme, where it goes from, instead of being like you go from being a mutation that's underactive to overactive, then they become really, really tall. So it's really interesting to know that. So acromesomelic dysplasia, as like, that's what I have, and I have two mutations. And my parents were slightly on the shorter end, but nobody would really think that or know that. They would just say, oh, they're from a short family, South Asian short family. And it's really maybe that they're on the side of short end because they're carriers for this condition. Now, CNP is so if you have excess, which works to the NPR2, then you're on the really tall end. So it's really interesting to know whether a gene can cause low function or high function, and how it causes opposite effects in some ways. And so that's really what helps to understand, okay, what can we do for treatment? And that's kind of how some of the treatments have arose. So we do have, for some of the rare diseases now, skeletal disorders, for X-linked hypophosphatemic rickets, where we should just give them phos and like vitamin D. Now we have a treatment that is given to as an inhibitor, so that way they don't have that overactivity of FGFR3. And then for hypophosphatasia, this is a different condition which I didn't go into detail about, but there's also an enzyme replacement that occurs and to help decrease the severity of the condition. This condition, it really varies in the severity of it and how severe it is. And so some people are more affected than others, and whether some may be treated versus others. Now with achondroplasia, as I was saying, some come from inherent families where like it's passed down to multiple generations, but 80% are born to average height parents. And in those families, a lot of them are like, what kind of treatment can we do? So now that we are at the growth plate, as I talked about, we have, there's so many genes involved. And so where in the pathway can we intervene to maybe decrease some of the complications? I mean, yes, growth is important, but I think that with achondroplasia, they have spinal stenosis, and they have other other complications that can, if that can be decreased by helping decrease some of the activity in a sense, or increase, then we would maybe avoid the complications, and that only time will tell us. But in the pathway, they've identified multiple, you can see all the yellow, of multiple different ways we could theoretically affect the pathway. And this is what's really exciting. This is how rare disease treatments are coming out like all the time. And it might just be 5 patients. And then that's how we say, oh, based on this pathway, let's try this. And then the drug gets approved. And there's a much faster approval process in rare disease drugs based on the type of condition it is. So recently, CNP analog, which works towards the same pathway of the achondroplasia pathway, it's got approved. It has been under clinical trials for many years, and it showed that if you did, it increased their growth by 1.57 centimeters per year based on the older age group when they studied this. And it's a once a daily injection. There's another one that's currently in clinical trial that's like a weekly injection, TransCon CNP. We'll see how that works. So if you theoretically give vosoritide every single day for a year, the kid would grow an extra 1.57 centimeters, which would be, if they took it for like 10 years, about 5 to 6 inches of growth. So instead of making them 4 feet, they may be 4'6", or from 4'6" to 4 to 5 feet. Some will say, is it really worth the $120,000 drug and an injection every single day? And I think the reality is, will it really decrease the complication rate? And some of the surgeries that these kids may have to go through, if it could decrease that, I think that's more life-changing. And that's what we're really excited to see if that will happen in the future. So, but FDA did approve achondroplasia conditionally in November 2021. And I think this is just exciting from a general, like how like you just understanding, going from a clinical diagnosis to a discovery of the gene, to now studying the gene and what it causes, to now having treatment, just tells you the advancement in medicine and how things evolve so fast. And not fast, but just it's just amazing how much understanding for us to understand conditions. And the question really is it going to decrease the complications that these children have, and surgeries they may need? or sudden death. So in achondroplasia, because of the foramen magnum, where where their skull goes to their spine is really narrow. Sometimes we have unexplained deaths initially. Now we know it's due to that. And if that can be avoided by starting these kids on injections from day one of life, maybe that's going to be life changing. And that's really what's going to be exciting to see in the clinical trials. And then there's also the debate of whether you should treat or not. And I think that's up to each family to decide whether or not they think it's worth it if they want to. The other issue is big question is always healthcare disparities. Is it going to be available to everybody? When it's $120,000 drug, that's always a question. But I still think that there is, discovering these treatments, it leads to more and more discoveries. And also, we don't know if there more and more people are on it, it will get cheaper over time, right? So I think it's still exciting that there is drugs out there. So the FDA approved it as a orphan drug. Orphan drugs are drugs that are for smaller populations. So like, unlike the COVID vaccine, which came out, it's studied in mass population. Here you have very limited, you can only have a limited number of patients. So there's a different approval process that happens. So in general, I always say, whenever we're treating a patient that has complex conditions, especially for children, but even in the adult world, I know we always think about, okay, there's the orthopedic surgeon, there's the geneticist, there's the neurologist, and the endocrine. But really, like and then we just expect the patient to go from to all these specialties. And I really think we need interdisciplinary care where, yes, maybe it's the primary care doctor, or it's the geneticist or the endocrinologist who is maybe making sure that some of the coordination of care happens. But I think it's everybody's responsibility in the kind of healthcare system we are in that we all communicate about how to best treat the patient. Because if a child has a skeletal disorder and they're at risk for complications, I think it's important the ENT speaks to anesthesia, who speaks to also the geneticist to understand what's going on, because these are not kids that people we're seeing every day in and day out. And interdisciplinary coordinated care definitely improves outcomes, I think, and even having psychology involved, right? What's the mental health of the patient, right? These kids are or adults, and later on are dealing with pain issues, or they're dealing with other complications. And I think with a coordinated team that's all on the same page, I think the care can be taken. And I really hope that we don't work separately, but we all work the team. But I think as we go through EMR with electronic medical records and everybody's in different practices, sometimes I have to tell these children that as they transition to the adult world, I'm like, you may not find the best doctors everywhere, but sometimes you just want to be in the same system. That way everybody can know what's going on. But I think our goal should be that no matter where you are, who you practice for, you want to have big coordinated care so we don't do over testing, and we can help make their improvement better. So some of the pearls, I would say, the height of an individual is determined by many factors. Be cautious as you give expectations of height or overall health, because if a pediatrician tells the parents, oh, your child's short, I think you should be on growth hormone. Do they really know if the kid qualifies for growth hormone? Do they know if growth hormone will even help? So really being careful what you're saying, expectations you're setting for the patient and the family. Nutrition, puberty, parasites, medications may all play a role. There are many, many genes that are involved that are not classical endocrine genes like growth hormone that affect growth. And there are treatments emerging for rare diseases. And sometimes those rare disease treatments will also be used for other conditions too. So it's always really exciting. Discoveries only help us make new discoveries. So advancing medicine, always learning, and your path is the way to go in healthcare. Even after you're done with training, you still have to keep learning. And the more you learn, the more you realize you don't learn. And then I really, really emphasize healthcare should be interdisciplinary for all patients. It's definitely a challenge in our current healthcare model, but we really should be talking to each other as we're taking care of these patients and figure out the best ways to improve that. I say all you need is steps to resilience, I guess, is what I would say as you're going through, and thinking and being a creative. So I can't rent a bike easily. I can't get a reasonable bike to my size. You get a custom made bike. You can advocate by saying, hey, Peloton, make a bike for me. But they might say no. Then you figure out your own ways. That's it. I would love to take your questions and see what thoughts you guys have.
Of course, thank you so much, Dr. Marchand. We really appreciate your mentorship and teaching. So we will now begin our Q&A session. My name is Minahil, and I'm a graduate from the University of Maryland College Park, who just applied to medical school, just waiting to hear back. All right, so start off our Q&A regarding your mention of growth hormone supplements and the psychosocial issues that are associated with it. In which cases would you actually prescribe these growth hormones to children?
So if you have a baby that's born and that's having low blood sugars, they sometimes have abnormal pituitary gland where they cannot produce growth hormone. So that's a no-brainer. They have growth hormone deficiency. They need growth hormone. And then there's other conditions, but I think that in general, growth hormone is overprescribed, especially in certain populations, because everybody wants to be taller. But there are definite indications where if you don't get growth hormone, you will have low blood sugars, and that can be like they can even have seizures from that. And so that's a whole different story. So I think that being aware that growth hormone doesn't make everybody taller is important.
Got it. Thank you so much. And how do you think that the social media ideals for a certain way for looks can be combated? I know that you mentioned before being more confident and other types of counseling for children that are increasingly exposed to social media, but do you have any other tips?
I think also like the society we live in, what we think of as it's like I think it's really hard, right? Social media, you only see one view of the world. You see one view of the way people imagine things, right? Or it's even comments like, oh, you should be fairer, or you should be like, you should lose weight, right? And those are all comments that in some ways, when I traveled around a lot as a kid, it was really interesting to me the way different people interacted, whether somebody would be like, hey, you want to help you, or it's not, right? Or and so being aware of those kind of I think just being aware of like how you interact with people, right? Like, are you judging somebody by something that's beyond their like that's not in their like they can't do anything about it, right? Like you don't that's not appropriate. Sometimes people define success as height, and I think that's a big issue we have in our society, which is why some of these parents and kids come crying in my clinic. And I think that is something we need to be thinking about, like because I wonder if I put somebody on growth hormone to make them taller as a child, do they as an adult view people or make friends that are taller, right? We don't, that's hard to study, but I wonder sometimes. And then the other thing is, how do parents perceive their kids? It's appropriate to come in for evaluation for growth, because sometimes when you're not growing, it could be an underlying condition. But it's another saying, comparing your kids to the other kids and saying, oh, my kid needs to be taller.
Thank you. Thank you. Really appreciate it. So speaking of, I know that you also mentioned late bloomers. So what causes children to be late bloomers? I know that there are a lot of reasons. So what are some of the most common reasons?
So sometimes if you have an underlying health condition that can delay your puberty, if you're underweight, like anorexia, or like athletes, sometimes their puberty gets delayed because they don't have enough nutrition to go through puberty. But there's also a genetic component. So sometimes if you have there are kids that are early bloomers too. So if parents are early bloomers, the kids tend to be early bloomers, meaning they just go through period, they start their periods earlier, for example, for girls, because it's much easier for a girl to recall when they started puberty versus a boy. But late bloomers means that they just started puberty later. So you know they don't the girls don't develop breasts, the boys don't have facial hair until much later. And so, and you grow until you're done with puberty. So if you had puberty early, you might seem taller, but then you're going to stop growing where other people are still growing.
Thank you. I think that offered a lot of clarification. Really appreciate it. So I know that we also spoke about proportions. So when doing surgery to increase height, I know that's something that some orthopedic surgeons do. The bones in the leg, I know I'm speaking in layman language, but the bones in the leg are sometimes cut and then moved apart. Does this procedure cause the proportions to appear off, or how do they coordinate with the rest of the healthcare team to prevent that?
So so limb lengthening is done for multiple reasons. So sometimes when you have limb length discrepancy where one extremity is longer than the other, that's like a medical reason to do it, right? Because that's going to have effect on your entire spine, your hips, because you're not walking comfortably. So that's commonly done for that. For skeletal dysplasias, some people may decide to do limb lengthening because they want to appear taller. It is a very long road, and it's somewhat controversial. Like I think I say it's up to each family and patient, and the child should be a major person who's deciding, because for 2 years it decreases the activity of the child while they're getting all these procedures and having screws in them. And like they're yes, maybe their extremities look longer, but you're not going to change the way they look. They probably will still look slightly, well, quote unquote, different. But I think that there is a lot of like the reason even the CMP analog for achondroplasia is coming about, I think, is not only the goal to make them taller, but that's an easier one to do is to get approved by the FDA because it's a measurable, right? Like it's hard to measure whether you decrease complications from like orthopedic procedures in a short period of time span. So drugs get approved based on one indication, but we're hoping for other indications. So I think that when I always say about skeletal dysplasias, I think the goal is not always to make them taller, but it's to make them have less medical complications. So with limb lengthening is really oftentimes just to make you taller. It's not going to change your risk of like spinal stenosis.
Thank you for the clarification. Something interesting I've learned about achondroplasia is that while the cause is a genetic mutation, only about like 1 out of 5 cases is hereditary. So what are some other causes of genetic mutations of FGFR3?
So like what are other conditions like hypochondria? So there's a less severe phenotype, which is hypochondroplasia, which I had mentioned. Like there's those they will not have the trident hand. They're not as short comparatively. Then you have the very severe form, or you have the form that's like where you have 2 mutations of achondroplasia. So if 2 parents have achondroplasia and they both have a child, there's a risk 25% that they have an affected child, and that's a lot more severe and it's more lethal, almost like they won't even survive. So there's a spectrum, and that's a lot of it has to do with based on where in the gene the mutation occurs and how the protein folding happens, that's how severe the condition is.
Thank
but
you.
there's a hot spot. There's a hot spot for achondroplasia, and that we know, and there's certain autosomal dominant conditions that tend to be more likely. So NF1, neurofibromatosis type 1, is also another condition that is commonly just in genetic mutation occurs spontaneously. Similar to like trisomy 21, like, or some of the trisomies, there is a higher risk with advanced maternal age. The autosomal dominant conditions are sometimes higher risk with advanced maternal age.
Thank you so much. Actually, that reminded me of like how it really makes us all feel really humbled where something so small like a protein misfolding happening in the body causing something so, at the large scale in the clinical level. So it's really humbling to learn, how our bodies work and function. Actually, I also wanted to ask, a lot of my friends who are male and also under 6 feet tend to feel that they're not tall enough, and that you mentioned that the 6 feet ideal for men. So how do you motivate these types of people or some of my friends, and do you have any advice for those who are considered short, air quotes, by society?
So I always say that's where I always say midparental height. You can't be expected to be 6 foot tall if your mom is 5'1" and your dad's 5'6". Like I see a lot of that, right? And I'm like, where is the 6 foot business coming from? Like it makes no sense. And so there's variation and there's so many genes that contribute to height. And I think that the problem is that there's nothing you can do about it. And I think we have much bigger problems in life. So if you're upset that you're not 6 foot tall and you're 5'6", we got other bigger issues. And then I always say sometimes it comes out of the parents. I'm like, what did your parents feed you? If they tell you that you should have been 6 foot tall, like that is not under your control.
Thank you, Dr. Merchant. That is helpful to know. And I think that, definitely there are things beyond height, but it is emphasized by society and social media, especially with our models. As you know, as a female, many models are over, 5'5", etc. So what I know that you mentioned some challenges facing healthcare, including interdisciplinary teams and patient care planning. What are some other challenges that you think are facing our U.S. healthcare system?
I mean, I think that insurance and what they're going to approve or not, which physicians will see patients or not. Like, I mean, it's really frustrating when I have a patient who has insurance and can't get in. The wait list for specialty care, and there is like the emphasis on kind of the combination of like whether or not we're treating patients for the sake of treating. Like one of the difficulties that I have is in the pediatric world, we're used to taking care of complex kids with a lot of health issues in a sense, but when they get into the adult world, they're living longer now, right? So a child with Duchenne muscular dystrophy may be living now into adulthood, but the pediatric world can't see them anymore. And so we have good multidisciplinary care in kids, but I think we need a lot of med peds doctors or adult doctors who are going to embrace and say, you know what, I'm not going to just see the straightforward adult patient, but I'm going to see complex kids and to adults who have autism, who have cystic fibrosis, who have Duchenne muscular dystrophy, or who have multiple medical conditions, and also figure out how to take care of them the best way instead of just throwing a lot of pain meds at them, for example, or just saying, oh, do this or expect to do this, or it's your problem. Because I think that sometimes we need to educate and learn ourselves on how to manage these patients. And I think from the adult practice, maybe learning from the pediatrics, like how do we do that? Because I think that's one thing that it's much easier at a big children's hospital for me when I do several multidisciplinary clinics because I have the neurologist who's there and the PM&R, physical medicine rehab, and a PT and a nutritionist. Um, Pediatrics does not pay well. So there's also like not a lot of people that go into pediatrics sometimes because of that, and they go into other fields for the money. And so I think that as we're thinking of medicine, what is the goal and how we really do want to improve care for children overall, but how do we help them when they get into the adult world?
Thank you. Now we're going to switch gears a little bit into your career and your residency, just for students who are interested in, or maybe picking out a specialty right now. So why did you choose to pursue pediatric endocrinology residency?
So when I was a kid growing up, I would say I'm very lucky that I was born and grew up in the US. But I kept from South Asian culture and I saw how people perceive genetics. And I felt like so much had to do with the way the parents perceived and society perceived them. And so for me, when traveling and interacting with people, I realized that I wanted to be the person who would help a family deal with their child's genetic diagnosis and help coordinate care. So I since high school, I was like, I want to be peds genetics. And at that time, it was really just, I wanted to be able to be there to help diagnose and help the family through. And then, but genetics field evolved and it's more diagnostic because now it's a very evolving field. But I wanted to continue to follow these kids. And so then I decided to do pediatric endocrine after I finished my training, as I was finishing up my genetics training, because I felt like that was a great fit for me of what I wanted to do. Because sometimes and especially after I started my training, I realized sometimes there's a kid born with a genetic condition or even a medical condition, and the parents don't survive the marriage, and sometimes, or you notice that amazingly the whole family comes together, right, to help this kid. The whole family, meaning extended family, friends. And to me, it's so much dependent on the society. Why is it that two children with trisomy 21, one may be more independent than the other, and it's a lot of it has to come down to the nurturing environment that the child is in. And I think that was, to me, very interesting. I know I wouldn't be where I am today if it wasn't for my parents and and the community that I grew up with and the schooling and I had. And so for me, it was what can I do from that standpoint?
Thank you, Dr. Merchant. That is really inspirational. I know that being a pediatrician, also a specialized pediatrician, you're also dealing with families a lot and a lot of parents. That's what yes,
yeah,
exactly.
Half of it is your parents or your diet. And I always say, even for adults, right, or even for children, you have to know whether they've embraced their diagnosis. If you tell somebody they have cancer and then they're denial, they're going to delay their treatment for 6 months, and that could change their prognosis. And so really understanding whether or not somebody has embraced their diagnosis and been able to look beyond makes a huge difference.
Thank you, Dr. Merchant. All right. And so how do you manage your work-life balance? I know that you're very busy. You're also an assistant professor. So how do you manage your work-life balance?
I think that that is always, I think that's something you make a priority, right? So you prioritize what needs to be done. And the med school residency fellowship pathway is very difficult. It's a lot of hours and a lot of exams and studying. But I think that you always have to prioritize giving yourself time to yourself, right? But you also need to not have that feeling of FOMO, the fear of missing out, right? So I think that when it comes to prioritizing, it's one of my mentors said, you got to choose 2 out of the 3. You can have a family, spend quality time with your family, or have a family, your career, or friends. And I think that you'll have to maybe let one go a little bit at some point, and especially as you get older, you can still have all 3, but there's going to be 2 that are going to prioritize over the third one. And then also when you're doing your search for jobs and stuff and that, you kind of want to know what the infrastructure is, and sometimes you don't know until you start. But I think I have a decent work-life balance. It's just you got to learn to prioritize in mindset. I think a lot of it comes down to that too.
Thank you, Dr. Merchant. And just out of curiosity, for our last two questions, can you walk us through a day in your life, as in what you do on a day-to-day basis, your hours as a clinical professor, kind of, are you teaching as well at the Children's National Hospital, as well as your patient load?
So I, as a clinical, well, I kind of transitioning a little bit more, but I do right now 2 to 3 full days of clinic. So that is like starting my clinic at 8, ending around 4:30. I see patients, except for that 1 hour lunch break, which sometimes I go over, but I see patients all through the day. And then I go from there. The other 2 days that I have, some days, some weeks is 3. It's really meetings, academic time, and then so like I have grants that I'm working on, some clinical research with, doing presentations like this kind of, and projects, coordinating care, following up with families and results, QI projects, just quality improvement. Those are all different types of things that you work on. And because I have an academic job, we have a little bit more protected time than if I was probably in private practice from that standpoint. And then mentorship, so working with trainees, residents, fellows, teaching, and then I do inpatient service. So like when I'm on for inpatient service, a couple weeks out of the year, then I'm on for the weekend too. So you'd go in and around through the day. And then you're normally there from 7 to 5 on a weekday. On a weekend, I'll just go in around in the morning, and then I'm on call at night. So, and like, because of endocrine, we don't wind up having to be in-house as much. So it's very different than if you're an emergency medicine doctor where you're there the whole time when you're on call versus, so it's, or other specialties. So yeah, I think that in a sense, because I'm in a more academic, I'm working with a lot of trainees. So your schedule is sometimes a little bit unique, where you might be working a lot more with a trainee at one point than another at different times.
Thank you, Dr. Merchant. That was a great snapshot. Just a follow up, you mentioned QI, quality improvement. Is that quality improvement of patient outcomes, or QI for administration, or?
So quality improvement, I mean, I do some quality improvement, but not a lot, but it's really like, it's an evolving door, right? Like we do something, you do an intervention, and then you see if it helps, right? So if you want to make sure your patients are showing up for follow-up, or you have diabetes patients and you want to make sure they're on technology, right? You do an intervention and then you see what happens with the results, because then it's more evidence-based, like, okay, this intervention worked, or maybe we need to improve this other intervention to see if we can improve that. I think that is a ongoing thing and that's more of your practice, and more like there is, and when we talk about research, there is like the big, like this discovery research, right? So that is at the level of like, working basic science, along with like clinical trials. Then there is the improvement of like healthcare overall. So like treatments wise, is this treatment working or not? Should we improve? Then there's the quality improvement where you know what standard of care, but how do we do it better? And that's what I talk about. So that often happens within an institution level.
Thank you,
Like
Dr.
hand
Merchant.
washing is a simple one. That's like a really popular QI project. They like, do we all wash our hands? What intervention we need to do to remind people to wash their hands?
No, that's great. I know that I see signs, employees must always wash their hands after using the restroom. So that those are helpful QIs, especially for our patients and improving patient care. For our last question, do you have any advice or further resources for students who are interested in learning more about your specialty or pursuing a career in pediatric endocrinology?
I think that when you are doing your job search, I think things like this are really important for like teleshadowing in the sense, or any, like when you're a pre-med student, oftentimes you kind of have an idea of maybe what you may want to go into. By the time you're done with residency or you're in med school, like 4th year, you've already kind of decided your path because of certain exposures, I would say. Like there's a lot of people that wind up going to certain fields just because that's what they were exposed to, right? Like if your father's a cardiologist, then you like, oh, I know what cardiology is, but you have absolutely no idea what pediatric endocrine is. Like I'm like, peds endo is a very subspecialty. So like we have a lot of kids that have diabetes, and they're like, I want to become a pediatric endocrinologist because I have diabetes. And so I think that knowing what's out there in the field is really important, and being open-minded, because lifestyle is a little bit different with each field. The and what the differences and what kind of jobs you're going to have. And what do you enjoy? Like, are you the person who wants to do night shifts all the time? Or do you want to be more like residency is different, but once you get into like faculty position and you're working, it's very different. And I think that those are things to be thinking about. But also asking questions like, do you like a field where like I like endocrine because I feel like I have a treatment for most things I treat with. I'm like, okay, you have a thyroid problem. I'll put you on thyroid meds. If you have diabetes, I'll put you on diabetes meds. It's all it is. So
Thank you so much, Dr. Merchant. Those are all of our questions we have for today. We really appreciate you taking the time to answer all of our questions and taking the time out of your day to mentor us. And I'd love everyone to please give a warm thank you to Dr. Merchant in the chat box for this incredibly informative session. Thank you.
Now we're going to conduct our closing session with our quiz and future session dates. So the link to the quiz for the session is now live. You'll need a 70% or higher to pass and receive certification, and that's being sent in the chat now. And for our next session dates, which will also be posted throughout our social media outlets, so be sure to follow us at TeleShadowing. Our next session will be next Saturday, July 23rd at 10 a.m. Eastern Standard Time with our physician mentoring us in internal medicine. Thank you so much, everyone, for attending today's session, and we hope to see you in upcoming sessions as well. This concludes this week's shadowing.